This is a case of a sclerotic jaw with a pathologic fracture. So the patient is a 55-year-old female with jaw pain and swelling and a history of metastatic ovarian cancer. Here's the patient's CT. This is a facial bone CT, axial section to the level of the mandible presented in bone windows. And clearly there's an asymmetry here. Lot to go over here. So couple things. One, you see the normal trabecular pattern here on the right, and then this sclerotic trabecular pattern here. So that's abnormal. What else is abnormal? You have this piece of bone that's surrounded by soft tissue. It doesn't appear to be connected to the rest of the mandible. And then you have this linear lucent line that goes from one cortex to the other. So what we have here is a fracture in an area of abnormal bone, and that's called a pathologic fracture. So the question is why is this bone abnormal? What's going on? So again, this falls in the category of an ill-defined sclerotic lesion in the mandible with aggressive features. And so what could this be? This again could be tumor. It could be osteonecrosis, either related to bisphosphonate use or radiation, or it could be osteomyelitis. So this patient does have ovarian cancer, so I would have to consider metastatic disease, and this patient also has a history of IV bisphosphonates, so I would strongly consider bisphosphonate-related osteonecrosis as well. So I went back and looked at this patient's history, and she had multiple PET CTs to follow up on her cancer. And PET CTs, it's a whole body CT along with the PET imaging. And the CT is not really of high resolution or diagnostic quality, but it did allow me to figure out what was going on here. So back in 2015, you had pretty symmetric and normal appearing trabecular pattern. Back in January of 2017, so this is 2 years later, you can already see there's some sclerosis. So this patient had been on the bisphosphonates for I think at least a year at this point. So nothing else, just a little bit of sclerosis. Fast forward then to May of 2017, and it's really hard to see on this non-diagnostic kind of PET CT, but there is already a linear lucency going through both cortices of the mandible. So here there is a non-displaced pathologic fracture. And then again, fast forward to October 2017, and you've got sequestra formation, pathologic fracture, you've got some evidence of healing with the periosteal reaction, but clearly this is not a completely healed fracture. This is not normal. So given the whole history of these images, I would strongly favor medication-related osteonecrosis. It doesn't look like there's a lytic lesion that ate up the bone first and then the fracture occurred. It looks like there was a gradual sclerosis of the mandible, followed by a non-displaced fracture, followed by an erosive process with sequestra formation. So that pattern is compatible with medication-related osteonecrosis. And one more thing, technically the diagnosis of medication-related osteonecrosis, unless they changed it, still requires exposed bone for 6 weeks, and there's a grading system, stages I think 1 through 3 based on symptoms and other things. But there is this notion of stage 0 medication-related osteonecrosis, which is when you have changes on the imaging but no symptoms, no exposed bone. So it's possible that back in January this patient may have had stage 0 medication-related osteonecrosis. I think it's important to mention, because even if you don't technically meet the diagnosis, I would want to know about it at that stage so that it doesn't progress to frank stage 1, 2, or 3 osteonecrosis. So let me just review the teaching points. So findings of aggressive mandibular lesions. I've gone over this before, but I'll repeat it here. Bone without soft tissue coverage, which again is more easily seen clinically than on imaging. Sequestra, a piece of bone that is not attached to the rest of the mandible or maxilla. cortical erosion, periosteal reaction, cortical expansion, and overlying soft tissue stranding. Now the first three I put in bold because those are more specific for a very aggressive process. A periosteal reaction, maybe minor trauma can do that. Cortical expansion, even a benign cyst can expand the cortex. So that's not as strong of a sign of an aggressive process. And overlying soft tissue stranding can be seen in a bunch of infectious, inflammatory, and other conditions. So the first three are probably the most important to know about. So again, the differential of an aggressive mandibular lesion with ill-defined sclerosis. And so I want to make sure it's clear that this is for ill-defined areas of sclerosis with erosion. If you see a big round mass with a break in the cortex, that's a different differential. Infection doesn't create a nice round mass-like structure. So things that are more diffuse like osteomyelitis or even osteoradial necrosis won't form a ball type mass. So just keep in mind, when I talk about this differential, it's for these aggressive processes with sort of ill-defined sclerosis. And again, it includes tumor, osteomyelitis, medication-related osteonecrosis, and radiation-induced osteonecrosis. And then finally, and I think this is really important, isolated sclerosis should prompt a review of medication and radiation history because it could present stage 0 osteonecrosis. And you can intervene at that stage by stopping the offending medication and hopefully prevent the patient from going on to clinically evident osteonecrosis and pathologic fracture.